I'm going to be talking about membranous nephropathy, and then the talk is the membranous nephropathy beyond Cytoxan and rituximab, but there'll be a chunk of time that I'll be talking about these two. So here are my objectives: to review the current KDIGO guidelines for management of membranous nephropathy, especially moderate to high risk, compare modified Ponticelli versus Mentor results, understand the issues with rituximab, and then I'm going to delve into the upcoming therapeutics in membranous nephropathy. So here's the KDIGO guidelines for membranous nephropathy. They usually recommend dividing it into different risk categories. So low risk would be somebody with GFR is preserved, proteinuria is below the nephrotic range, albumin is more than 3 grams, and those who respond with RAS blockade with at least 50% drop in proteinuria. But as you go from low to moderate to high risk, there's a drop in GFR, the proteinuria gets higher, and especially in high risk, there's less than 50% drop in proteinuria after 6 months of RAS blockade, and then they have low albumin, less than 2.5 grams, high PLA2, low to moderately high PLA2R titers, and then spilling of other proteins like alpha-1 microglobulin, urinary IgG, beta-2 microglobulin, with urinary proteinuria selective index of more than 0.2. So proteinuria selective index is a clearance of urine IgG divided by albumin. And very high risk would be, those whose GFR deteriorates very rapidly, very high proteinuria, and then life-threatening nephrotic syndrome. And this is how they would recommend, you risk evaluate them. If it's low risk, you just wait and see to see if they spontaneously remit. Moderate risk, you could wait and see or try rituximab or CNI. High risk, they recommend rituximab or cyclophosphamide. And very high risk, they recommend cyclophosphamide with steroids. So I'm going to briefly talk about modified Ponticelli versus Mentor. So the modified Ponticelli regimen is an alternative regimen of steroids compared with, and steroids alternating with Cytoxan. So the steroid months are month 1, 3, and 5. Cyclophosphamide months are 2, 4, and 6. We give methylprednisolone daily for 3 days, and then followed by prednisolone 0.5 milligram per kilo for 27 days. In the original Ponticelli protocol, they used chlorambucil, which has more side effects compared to cyclophosphamide. And then subsequent study by Jha et al. Used Cytoxan 2 milligrams per kilo per day. And in the Ponticelli trial, the supportive arm just were on the control arm only had supportive treatment, and the duration of follow-up was 10 years. The Mentor trial used rituximab 1 gram 2 weeks apart, with another gram in 6 months if the patient attained partial remission. So partial remission would be 50% drop in proteinuria with proteinuria below nephrotic range. And the comparator was cyclosporin, 3.5 milligram per kilo for 6 months. And the follow-up duration was 2 years. And here's the comparison. So Ponticelli had 42 versus 39 patients. Mentor has at least 65 patients in both arms. The subsequent study by Jha et al. Was done with cyclophosphamide, whereas the original study with Ponticelli was with chlorambucil. There were more ESRD in the control arm in Ponticelli, and Ponticelli control arm only received supportive care, versus ESRD was not reached in Mentor trial. The remission rates, both complete and partial, were similar, but if you look at the study by Jha et al., cyclophosphamide had a remission rate of roughly 72% compared to 60% with rituximab. And in Ponticelli trial, 9.5% of the patients relapsed and all responded to repeat course of alkylating agent, whereas 5% of the patients in the Mentor trial relapsed, but the follow-up duration was only 2 years. And then there were more deaths in the control arm in the Ponticelli compared to this with the alkylating agent, but none in the Mentor trial. But the follow-up duration for Ponticelli was 10 years as opposed to 2 years for Mentor. And so, which one is better? Is cyclophosphamide better than rituximab? So we don't have a head-to-head trial, but there was a pilot trial called RI Cyclo trial, which was published in JASN in 2021. Here, there were 74 patients with primary PLA2R positive membranous nephropathy with creatinine of 1, and they were on conservative treatment with RAS blockade. And then they were randomized to either rituximab or cyclophosphamide. So rituximab was given in day 1 and day 15. Cytoxan alternating with steroids for 6 months. And the primary outcome was analyzed at 12 months. And then the secondary outcomes were analyzed subsequently with the total follow-up duration of 36 months. So blue is rituximab, red is cyclophosphamide, and you can see the proteinuria graph. So red is cyclophosphamide. So you can see the proteinuria drop was faster in the cyclophosphamide arm. The increase in albumin was faster in the cyclophosphamide arm, but over time, the rituximab arm caught up. And at 12 months, at least, the CR was higher in cyclophosphamide compared to rituximab, but the odds ratio crossed 1. But over time, the rituximab arm caught up. So, is I mean, this certainly looks like, Cytoxan is better at attaining remission faster. And what the authors concluded from this pilot study is that even to have a global non-inferiority trial, comparing cyclophosphamide with rituximab would require recruitment of large number of patients and longer follow-up. So it may not be feasible to do that. Before I delve into the issues with rituximab, here are the things that we need to know. The Euroimmune ELISA cutoff for PLA2R. So low titers are considered between 14 to 86, moderate between 87 to 204, and high would be more than 204 units per ml. At Harborview at Montlake, we use indirect immunofluorescence for as opposed to ELISA to measure PLA2R. So now I'm going to delve into issues with rituximab. So number one is that rituximab does not work very well if the baseline PLA2R titers are high. So this was a study from France where patients were treated with cyclophosphamide 1.5 milligram per kilo per day for up to 24 weeks. So this is with Ninj cohort. And they were compared with patients who were treated with rituximab. This was the French cohort. So you can see the PLA2R titers and disappearance of PLA2R titers after 6 months. So red is if the PLA2R titers are still positive, blue is if the PLA2R titers are negative. You can see that as the titers start to increase, Cytoxan can still maintain negative PLA2R titers. Whereas with rituximab, if the titers start to increase, if the titers are extremely high, rituximab is not able to cause immunological remission. It cannot cause a drop in PLA2R titers. And the second curve is compares ELISA titers after 6 months of treatment versus ELISA baseline titers. And you can see this is the ELISA cutoff of 20 RU per ml. So you can see at 6 months, cyclophosphamide is able to convert all of them blue, meaning negative, whereas with high titers, rituximab is still red, meaning rituximab is not able to cause any change in PLA2R titers. So rituximab does not work very well if the titers are high. The second is the concept of PLA2R epitope spreading. So as we know, primary membranous nephropathy, and then I'm going to be talking about PLA2R primarily, is a disease where antigen-presenting cells with class 2 MSC, especially DRB1 or DRA, present antigen to T cells, and they in turn secrete cytokines, and they cause B cells to differentiate into plasma cells, and plasma cells then produce antibodies to the PLA2R antigen podocytes. The concept of epitope spreading is not new. Epitope spreading is the phenomenon given by nature where an immune response can contain an infection, a cancer, where there's an immune response against a small epitope of the antigen, and over time, you form more and more immune response against more and more epitopes of that antigen, so that the infection or inflammation or the tumor spread can be contained. So figure A is the structure of PLA2R. This is the N terminus, this is the C terminus. It consists of cysteine binding domain, fibronectin binding domain, 8 CTLD binding domain, and there is a transmembrane domain, and then and a collecting domain. And normally the cysteine binding domain interacts with CTLD binding domain 2, and the interaction is pH dependent. Whereas the fibronectin binding domain interacts with 6, and this is a pH-dependent interaction. So depending upon the pH, whether it's acidic or basic, it can have either a fist-like structure or an elongated structure. So there were 2 papers that were published about epitope spreading hypothesis. And one paper cited that the epitope spreading is very linear. So you initially form PLA2R antibodies against cysteine-rich domain, then you form against CTLD1 and then 7. And what happens is that as the epitope spreading happens, the urine protein excretion increases, and then that happens as they tend to get older, and then the likelihood of remission from membranous nephropathy, I'm talking about spontaneous remission, decreases. There was a second paper in JASON that cited that you can have multiple epitopes to the PLA2R antigen at baseline. So the PLA2R epitope spreading may not be linear, and they usually correlate well with total PLA2R antibody levels, and the likelihood of remission is low. Meaning, if your total PLA2R levels are very high, very likely you have antibodies against various epitopes of PLA2R, and the likelihood of spontaneously remitting, we used to talk about 1/3, so 1/3 of membranous nephropathy patients would spontaneously remit, the likelihood of remission would be much lower. The second issue with rituximab is resistance. So this is the cartoon of rituximab. You have these light chains and heavy chains, and the antigen binding site has a murine portion, whereas the FC region is fully humanized. So rituximab, even though it's a monoclonal antibody against CD20, it's not fully humanized. And rituximab binds to CD20 of B cells, and then they in turn can activate complement via classical pathway and insert membrane attack complex and lyse B cells. Rituximab can also bind to the complement receptor natural killer cells or the FC receptor of natural killer cells, and they can via perforin granzyme pathway cause lysis of the B cells. Or rituximab can bind to FC gamma receptor on macrophage and cause antibody-mediated phagocytosis. And one of the causes of rituximab resistance is this polymorphism in the FC gamma receptor that we don't understand very well. So rituximab was originally used in oncology for B-cell lymphomas, and then over time we have newer fully humanized antibodies. So ofatumumab and obinutuzumab are fully humanized, and their killing is slightly different. So ofatumumab is, even though it's fully humanized, most of the killing is via complement-dependent cellular cytotoxicity. So it binds to the CD20 on B cells, and then via classical pathway causes complement activation, and that in turn causes lysis of B cells. Obinutuzumab has defucosylated FC portion, so it does not fix complement very well. So the direct killing or the antibody-dependent phagocytosis is much more compared to rituximab. And you can see rituximab has murine variable regions, and these two antibodies don't. The other issue with rituximab is where it binds to CD20. So this is the structure of CD20. You have the N-terminus and C-terminus, which are intracellular, and you have a small loop of rituximab, small loop of CD19, and a larger loop. And rituximab only binds to the large loop of CD20, whereas ofatumumab binds to both small and large loop. So because rituximab only binds to the large loop and ofatumumab binds to both small and large loops, the degree of B-cell depletion with rituximab is short-lived compared to ofatumumab. And hence, the B cells can reconstitute faster with rituximab compared to ofatumumab. And there have been several case reports of the newer monoclonal antibodies used in refractory membranous nephropathy, both ofatumumab and obinutuzumab. But we have two clinical trials that are pending with obinutuzumab. One is a phase 3 trial, and one is a pilot trial with 20 patients. The pilot trial is done in patients who can't tolerate rituximab or who have resistance to rituximab, whereas the open label phase 3 is done in 150 patients with membranous nephropathy. Because rituximab is not fully humanized, you can make antibodies against rituximab that can confer resistance. So you can form anti-rituximab antibodies. So this was a study that was published this year where they looked at 55 patients with primary membranous nephropathy from France. 85% of them were PLA2R antibodies. And anti-rituximab antibodies were formed in 21 of those patients, so 38%. And 86% of them formed anti-rituximab antibodies after first infusion. And they were detected at the median of 9 months. When you look at patients who had anti-rituximab antibodies versus patients who did not, they tended to be heavier. They tended to have lower vitamin D level. I mean, this could be a reflective of being vitamin D binding protein in the urine, or having a role of vitamin D in immune modulation. They tended to have slightly lower albumin, but this was not statistically. What was statistically significant at baseline is that patients who had anti-rituximab antibodies had a higher PLA2R titers, more epitope spreading, and higher level of inflammatory cytokine IL-17. So that because of these, they needed a higher dose of rituximab. And because they form anti-rituximab antibodies, the CD19 count at 3 months was higher in the patients in the arm where anti-rituximab antibodies were present. At 6 months, however, even though patients with anti-rituximab antibodies had lower albumin, higher urinary protein, higher titers of PLA2R, more epitope spreading, and faster constitution of CD19, this was not statistically significant. However, the remission at 6 and 12 months were lower in patients who had anti-rituximab antibodies compared to those who did not, and this would make sense. But this did not reach statistical significance. The one that did was the relapse before 24 months. So patients who had anti-rituximab antibodies relapsed before 24 months at 38% compared to 15%. And this was a proposed algorithm in one of the papers. What to do if patients have anti-rituximab antibodies is, if you have anti-rituximab antibodies, you can freeze them for 5 to 7 cycles, and then if you have a response, then give rituximab, or if you have a resistance, then you use one of the newer monoclonal antibodies. And if you don't have anti-rituximab antibodies at baseline, then you just repeat rituximab infusion at a higher dose. The third thing about rituximab is that you lose, because it's an immunoglobulin, you end up peeing in the urine in nephrotic patients. So this was a study done from Mayo Clinic where 20 patients with idiopathic membranous nephropathy were studied. All of them were on RAS blockade, and they were treated with rituximab 375 milligrams per meter square at 6 months. At baseline and at 6 months. So this is baseline, this is 6 months. And they were compared with patients who had rheumatoid arthritis. So who were, again, treated similarly with 375 milligrams per meter square per week at month 0 and then month 6. So this black line is the rheumatoid arthritis with 5th and then 95% confidence interval. And these gray bars are rituximab. So you can see at baseline, the rituximab and then the rheumatoid arthritis arm often overlapped. But you can see the rituximab concentration over time in the membranous nephropathy arm dropped. Whereas at 6 months, when the infusion was given, they overlapped, but the drop over time was less significant, meaning, with the improvement in proteinuria, rituximab stayed in the system, and then the concentration was similar to that of patients with rheumatoid arthritis. What he also concluded was the serum half-life of rituximab in rheumatoid arthritis was 18 days compared to 11.5 days in patients with membranous nephropathy. The second curve talks about CD19 counts over time. So this dashed line is idiopathic membranous nephropathy that were treated with 1 gram 2 weeks apart at baseline. And you can see the B cell reconstitution was faster in that arm compared to this gray line of idiopathic membranous nephropathy treated with 375 milligram per meter square per week for 4. So if you give rituximab 1 gram 2 weeks apart, the B cells reconstitute faster compared to if you give 375 milligrams per meter square per week. However, rituximab did not have any correlation with urinary protein, serum albumin, the degree of urinary protein drop, or time to remission. So because of that, we think that 1 gram 2 weeks apart is as good as 375 milligrams per meter square per week. But the two other curves are patients with rheumatoid arthritis and ANCA vasculitis who don't have much proteinuria at baseline. So because they don't have much proteinuria at baseline, they don't lose rituximab in the urine, so that the B cell depletion stays longer. Now I'm going to switch gears and then talk about the upcoming therapeutics in membranous nephropathy. And this is a cartoon of B cell development. So you have pro B cell, which in turn forms pre B cell, and you start seeing CD20 expressed on their surface. And then immature B cell also has this BAFF receptor, BCMA or TOSI, and then B-lyse binds to this receptor, which in turn can cause B cell proliferation. So we have a blocker of B-lyse, which is belimumab. Then you form mature B cell and activated B cell, and then they in turn form plasmablasts and plasma cells. So plasmablasts have these CD38 and CD138, and then over time they lose their CD20. So the upcoming therapeutics are in the complement world. So you have these antigen-presenting cells, which in turn stimulate T cells, and they in turn stimulate B cells to produce anti-PLA2R antibodies against the various domains of PLA2R. And they form immune complexes which deposit in the subepithelial space. And they in turn activate complement via both alternative pathway as well as lectin binding pathway. So in primary membranous nephropathy, PLA2R mediated membranous nephropathy, the antibody that you form is primarily IgG4. And IgG4 does not fix complement via classical pathway. And normal IgG4 is glycosylated, but the anti-PLA2R antibody usually has less glucose and is hypoglycosylated. So it binds to the PLA2R and causes activation of complement via alternative pathway or managed binding lectin pathway, eventually leading to formation of membrane attack complex in podocytes. And the C3a and C5a bind to the receptors on podocytes, and they in turn lead to generation of these proteases, which in turn digest the synaptopodin and slit diaphragm protein, and then you eventually cause proteinuria. So we have 3 clinical trials pending in the membranous nephropathy world. One is BCX9930, which is a factor D inhibitor, iptacopan, which is a factor B inhibitor, and we were testing iptacopan in IgA nephropathy patients until recently. It was a phase 3 trial. And narsoplimab, which is a mannose-associated serine protease inhibitor, which inhibits the lectin pathway. So these are the 3 drugs in pipeline, and then they're being tested mostly in membranous. Some are also being tested in C3G as well as IgA nephropathy. We have started using a B-lyse inhibitor, belimumab, in lupus nephritis after BLISS-LN trial. It has also been studied in membranous nephropathy. So this was an open-label trial of 14 PLA2R patients who were treated with belimumab, 10 milligram per kilo every 4 weeks until week 100. And the primary outcome was change in UPCR or PLA2R antibody at week 28. So you can see these squares are PLA2R titers, and then these round ones are the UPCR. So you can see with belimumab, the PLA2R titers decreased over time, and then proteinuria followed. So that 2-year treatment with Benlysta was associated with UPCR reduction by 86% and drop in PLA2R titer by 97%. And this has led to the reboot trial, which is similar to the Calibrate trial in lupus, where patients with PLA2R positive membranous nephropathy would be either randomized to Benlysta every week for 1 year, and they would be given Rituxmab at week 4 and 6. This is part A, whereas in part B, group 1 would receive similar treatment, whereas in group 2, instead of belimumab actual drug, they would get placebo. And the reason why they're giving belimumab every weekly as opposed to every 2 weeks in lupus followed by every monthly is that because it's an immunoglobulin, we also end up losing belimumab in the urine, and the efficacy may decrease. So hopefully we'll get the results of reboot trial in 2024, 2025. Bortuzumab has been used in membranous nephropathy, but mostly case reports. So this was a patient who received treatment with rituximab, 375 milligram per meter square per week, 2 sessions. And this blue is the PLA2R titers, and the titers did not decrease. And then the patient was then switched to bortuzumab and dexamethasone, 1.3 milligram per meter square per week, along with dexamethasone, day 1, 8, 15, and 21. You can see the PLA2R titers improved over time, and then the proteinuria followed. This is a second patient who had resistant membranous nephropathy who got treated with rituximab, 2 courses, and was on a stable dose of tacrolimus. And rituximab led to hypogammaglobulinemia, followed by treatment with cyclophosphamide, but then that led to neutropenia. and not a much drop in PLA2R titers. So the patient was eventually freezed and then was treated with bortuzumab and dexamethasone followed by bortuzumab. So you can see this purple figure of PLA2R titers, that the PLA2R titers improved over time. So this would make bortuzumab a potential contender for membranous nephropathy, but currently we do not have any trial with proteasome inhibitor in membranous nephropathy. Anti-CD38 antibodies are currently being used in myeloma, and after Andromeda trial, also in AL amyloidosis. So most of these antibodies bind to CD38 on the surface of plasma cells, and they kill plasma cells via complement-dependent, antibody-dependent cell-mediated cytotoxicity and induction of programmed cell death. This is a figure where the PLA2R titers were tracked over time. This is a patient who had refractory membranous nephropathy, ended up getting daratumumab every week, followed by every 2 weeks, followed by every month. And then the PLA2R titers decreased, but then started to rise. And then when they did a B cell profiling, they realized that because we're blocking antibodies at the plasma cell level, the pre-B cells started to reconstitute. So the patient ended up getting 2 doses of rituximab, and that in turn led to a drop in PLA2R titers. We do not have any clinical trial with daratumumab, but there are 3 clinical trials pending with felzartamab, which is an anti-CD38 antibody. So hopefully we'll get the results the next year or the year after. And then some of them have been studied in patients who have had resistance to rituximab. There are a couple of experimental therapies. So the left cartoon is about CAR T cell therapy. So CAR T cell is currently being used in refractory leukemias and lymphomas. And we have a study of 5 patients with refractory lupus where CAR T cell is used, where a CAR T cell with the PLA2R domain, which is bound to the co-stimulatory domain and CD3 zeta, binds to the B cells that are expressing the PLA2R and then would cause direct killing of autoreactive B cell. The right-sided cartoon is a picture of sweeping antibodies, where you give a sweeping antibody which has antigen binding site for PLA2R domain. So it'll bind to the PLA2R in the blood, would then bind to the Fc gamma receptor on the surface of cells. And then the PLA2R antibodies would be internalized and digested in lysosome, and then these sweeping antibodies would get recycled. Another therapy would be immunoadsorption, where instead of plasmapheresis, you're performing immunoadsorption, and then that would lead to decrease in antibody titers. This has been used in patients who have had THS-D7A positive membranous nephropathy in the setting of tumor. And the last one that I haven't discussed is the BTK inhibitors. So Bruton tyrosine kinase inhibitors are used in CLL, and they in turn block the signal transduction pathway in B cells, leading to decreased B cell proliferation. So ibrutinib would be the classical drug. And they are currently being studied in other autoimmune diseases such as lupus nephritis and rheumatoid arthritis, and hopefully would be studied in membranous nephropathy in the future. So to conclude, number one, high-risk membranous nephropathy patients, especially if they have high PLA2R titers, they tend to benefit from cytoxan as opposed to rituximab with respect to faster drop in proteinuria and then drop in PLA2R titers. PLA2R epitope spreading, incomplete B cell depletion, formation of anti-rituximab antibodies, and loss of rituximab in the urine are causes of rituximab resistance. And then the upcoming therapeutics in membranous nephropathy include the use of completely humanized antibodies, complement blockers, and then CD38 antibodies. And yeah, thank you.
Thank you, Abbal. Maybe time for just one question. It looks like, Kim, you had some discussion going in the chat if you wanted to comment.
I was just wondering if we actually had an assay for the Rituxan antibodies here, or how we go ahead and do that. And then the other aspect is most of what you presented, Abbal, is based on having anti-phospholipid A2 receptor antibodies. And I presume you think that if your membranous is due to some other antibody, the treatments would be similar?
Yeah, so the AntiRituxmab antibodies is a sent out test. You can add, order lab undefined and type AntiRituxmab antibodies, and I don't know where it's sent out to, but you can get that. I've had a patient who relapsed multiple times in rituximab, had a good B cell depletion, and I couldn't get him covered for obinutuzumab, so I checked AntiRituxmab antibodies, and it was negative. The second question about, most of the data is with PLA2R membranous nephropathy because that's present in 70 to 80%. So I presume, others would be similar. The second most common antigen would be in L1, but we do not know. I mean, most of the study with epitope spreading and so forth is with PLA2R as opposed to others. But the principles with respect to rituximab, like loss of rituximab in the urine, formation of anti-rituximab antibodies, and incomplete B cell depletion with rituximab compared to other newer fully humanized antibodies would be similar.
Thank you, Abbal. I personally will have follow-up questions with you that I'll want to discuss, but we'll move on for time. Thank you.